Hello, everybody. My name's Ira Kirschenbaum. I am, aside from being the chairman of orthopedics at Bronx Care Health System in New York, I am the editor and publisher of the Journal of Orthopedic Experience and Innovation. We have the pleasure and honor of having two special guests tonight, Dr. Yair Kissin and Dr. Eytan Debi. We also have the great pleasure of having an incredible sponsor tonight, Think Surgical, and we'll be talking a lot about the Think Surgical line of products and their approach to how joint replacement currently and possibly in the future will be done in many ways. What I would like to do first is just have the faculty introduce themselves. Yair, you want to go first, please?
Hi, good evening. Yair Kissin from over in Hackensack, New Jersey. Really a pleasure and honor to be here. Ira, you've really set up this format so well. I've been a spectator and I've been a participant, and it's been a really good way of getting good information out there to whoever wants to join. So hopefully we can learn a little bit from each other tonight.
Great, thank you. And Eytan, Dr. Debi.
Hi, everyone. Eytan Debi. I'm a hip and knee replacement surgeon here in New York at HSS. A big passion in tech for technology, so I really love these meetings. Love the journal. Love the kind of passion on pushing the needle forward on all the exciting stuff we can provide for our patients, and looking forward to a great conversation. And thank you for the invitation back again.
Thank you. And so we're going to start and we're going to talk tonight about how robotics enable choice in arthroplasty, total knee replacement. And I bring that up because everybody knows you buy the big robot from company X and you are locked in to company X products. And the robot doesn't cost $52.25. It's you know, it's almost as much as spine surgeons make. Okay, that's all I can say. Okay, so it's expensive, a robot. So let's talk a little bit about with both of the faculty. Eytan, we'll start with you about your recent experience with the TMINI and TKAs and how you came about looking at this problem of alignment and navigation and to use this Think MIDI.
Sure. So I'll kind of just take it one step back. I've had a lot of experience with a lot of different robotic systems. I'm a believer in the use of technology in the OR for hip and knee replacement. I think in particular knee replacement, I've found excellent outcomes with robotic surgery. I've used pretty much every robotic knee replacement tool out there. I think that I'm also a believer in providing the most personalized implant choice per patient, whether that be something that's patellar friendly, whether that be something that's medial stabilized or medial pivot, whether that be something that's metal allergy. Every surgeon I think wants to provide that for their patients, and until now, I think we really have this kind of discrepancy between these kind of two voices in our head between providing the best technology but also providing the best implant, we think. With Think, I think it takes a lot of thinking out of that equation, and allows you to basically use the implant that you think is best for the patient, but also provide that technology for the patient. And I think that right now, that's really been allowed with the Think Mini system, and I'm looking forward to kind of progressing that moving forward.
Yair, how about one, your experience, and I'd like you to describe the robot for me. You know,
Cool. Yeah. So, likewise, I've had some experience. Eytan definitely has been the robot king in our circle here. But we've at Hackensack, we're lucky enough we have had the Think Maxi robot, the big one, the autonomous robot, which I've been using since about 2017, and it was a great tool. That was a tool that came in autonomously, went to town on the knee and got, accurate cuts, and nothing bad happened, but it added extra time. It changed the workflow. We couldn't stand on one side of the table. That you had to put, X fix pins into the patient to hold it to the robot. and you were beholden to the plan, so you couldn't make any changes. So it wasn't as attractive to everybody as maybe we would have wanted it to be. They took that technology and now put that streamlined it into a handheld wireless device. So literally, the robot, it feels like, it looks like a just a big drill in your hand, and the eyeballs basically are above the table, so you everyone can stand where they normally belong. And the way that I look at this is that, having done cases now with this device, after we did a bunch in the lab to try to make it better, I'm just doing a total knee replacement, the way I almost normally was doing it before, now with a real bullseye, towards a really good finish line. Kind of like when you buy the GPS from the car manufacturer, you're locked into that GPS. Maybe you can get an update, software update here and there. You sell the car, you lost your GPS. I think we all wanted a GPS that we can put in the car, or in my wife's car, or in a rental car. But not only that, it had to actually work and actually get us to the destination. So this is the first robot, after using about 3 or 4 different kinds, that I feel like we're actually there, where we have a device that doesn't feel particularly foreign to the way we do a knee replacement and have always done a knee replacement. But it a little, I'm being humble, I think it's quite an enhancement to what we're doing. And it allows us to very quickly and efficiently and safely and smoothly and universally, I think it's very easy to learn for anybody, because I think people have been doing this a while. Adoption of a new robotic system where they have to bring in these giant robots, not so adaptable. This is just easy.
Let's talk a little bit about pre-op planning. And we'll talk about the comparing pre-op planning in a non-robotic knee. I refuse to call it a conventional knee. I'm sorry, or one day it'll be called a legacy knee, right? It'll be something like that. But in a non-robotic knee versus a TMINI knee, Eytan, let's start with you. What do you feel pre-op? What's going on? What's the differences? What controls do you have? Um,
Sure. So I think, and I think it's less dichotomous than that. I think, you have our traditional knee replacement, pre-op X-rays, let's say, maybe some long lending alignment films, hopefully a preoperative exam. You're going in, you have a plan. You're going to get your sizes based on your preoperative planning, and some intraoperative assessment of sizes, and making some decisions intraoperatively. I think the vast majority going mechanical alignment, and those who are more have that kinematic flair or have that training are maybe doing a little bit of kinematics built into that as well. And then we kind of moving forward, I think we've kind of accelerated our technology in the OR. We have our navigation systems, which may allow us to add a little bit more alignment, kinematic alignment, a little varus on our tibia, valgus or varus on the femur, things like that, and rotation. And now we're moving into robotic planning. And I think with robotic planning, right now there's really kind of there's basically two main ways to look at it. One is navigation systems, that have imageless navigation systems, and then there's image-based navigation systems, and they're both robotic applications. And I've used all of them, and I think there's pros and cons to all of them. I think with the imageless robotic systems, there is some preoperative planning, but there's no CT scan, right? So a lot of it comes back to some traditional things that we feel comfortable with. Good X-rays, hopefully long leg alignment films, and a physical exam. And then all the magic really happens intraoperatively, right? So you're doing your intraoperative assessment of sizes and gap balancing and making adjustments with the
mhm.
robotic systems live in the OR. The image-based navigation systems add a little bit of more depth to that preoperative planning. So um, image-based navigation systems right now traditionally use CT scans and give a lot of depth to that planning, right? So before surgery, you pretty much know your sizes. You pretty much know if there is significant bone cysts. if there's hardware, you pretty much know if the hardware is going to get in the way of your implants. If there's osteophytes, you're getting a better assessment of that. Will that affect your balance intraoperatively? Will it not? Is there a certain osteophyte you have to go after? Is there some sort of extra-articular deformity interfering at the joint line? You get a lot of that from the image-based navigation systems. In this particular case, the Think Surgical robotic system is an image-based navigation system, so it uses a CT scan for planning. And again, there's pros and cons with that. Most of it is pros, right? So you get that extra depth of planning. Con, whether you look at it or not, you need a CT scan, right? You can't, get a CT scan with your eyes. You got to send the patient to get a CT scan. And I think, CT scans now are low dose and easy to obtain, and that threshold is a lot lower and cost is lower. So I think it's not as onerous as it used to be. But right now, that gives a little bit of more depth on the preoperative planning. And so pretty much when I enter the OR, I don't think I've ever changed an implant size for the femur with the Think Surgical system. The tibia is not hit or miss. You're within one size, but we're like, generally, it's either, let's say, a five, it's either going to be one up, one down. We'll see where this base plate sits based on the rotation of that component and your implant system. So I think that gives a lot of benefit for the sizing, particularly in surgery centers. And that's where I think the TMINI really shines in terms of a footprint. Um, and so that's where I kind of see the spectrum of preoperative planning as we are today.
Yeah. Do you think in your hospital, if as you adopt something like the T-Mini with this pre-op planning, you're going to really decrease and do some just-in-time delivery of implants and a variety of things like that to decrease the delivery costs and increase the efficiency in the OR? Or do you think the hospitals are just going to continue doing it the same old way?
I think the hospital's going to shift to, like Eytan alluded to, the surgery centers where they can be the most efficient model. If they know what size they're going to do within one or two, having never changed a femur once and changed a tibia on purpose, because we know maybe we'll be a little bit uncovered or overcovered. So there, it's so easy to know those sizes ahead of
Yeah.
time. For me, the CT scan, has really added a lot. I know it's one extra step. I know it is a little bit of a conversation with patients, that yes, there is one I know you came to me, you heard you saw somewhere that I do this thing. It does require a CT scan and nobody blinks.
Yeah.
I had only one patient who their insurance didn't cover it. The trick that I found is you write, it's osteoarthritis and genu varum or genu valgum preoperative planning for deformity. It's never really been a problem. In that one patient that it wasn't covered, they paid for it. And it's really a few $100. It's really not
Right.
particularly prohibitive. But the sizing part is so important, especially we're pretty blessed with some of our implant systems where you could put a giant femur on a tiny tibia and it's okay. A lot of implant systems are one up, one down. And when you use those systems, you're sometimes making compromises and you feel like you might have to upsize, downsize, or basically feel like you're putting in the wrong size. But if you can preoperatively put it where you want it, how you want it, that's a big deal. The CT scan, I think what it adds mostly for me is that corroboration of a preoperative idea of where I want this knee to end up and what I want the post-op X-ray to look like and what I find intra-op. So I've done imageless on one system where it has an option for image, pre-op imaging, both X-ray and CT scan with this particular system. And the designers that I'm familiar with don't do that. So I just do it their way, which is imageless. And I find that then when I'm registering that knee, I really have one point of reference. And I've seen some inaccuracies. I haven't been able to make it as accurate as maybe some other people can do with imageless. What I find is with the pre-op CT scan, intra-op registration, if those two collide and corroborate with each other, I'm really going to hit the mark that I'm looking for. That to me is a big deal.
Yeah, I want to hit you guys up with a tough question because I'm in the mood for that. Okay. And I want you to imagine you went through Calvin and Hobbes duplicator and there was two Yair Kissins and two Eytan Debis, okay? And one of them just did traditional knees, trained at the places you guys trained at, superb places. And one started with the something, of course, like exactly the TMINI or the TMINI Pro or something of that nature. 10 years later, what would be the value proposition essentially for the TMINI? Would you feel you are which person is balancing the knees better? Which person is a better knee surgeon? It's each of you. You know, Eytan, tough question or non-question?
I think there's no better. I think that's probably not the right term for it, and I
Okay,
think everyone has
fair.
probably their own mindset, right? I think the Debbie that was trained traditional and is doing traditional. Um, Hopefully they are trained well, that they're balancing their needs appropriately without robotics, and they're kind of they get that end result with however they're getting there. I think that the Debi that's using more robotic systems, and this is something we're actively studying now, and all our patients that are in our studies do full gait analyses before and after surgery, robotic system or not. But I think they end up hopefully with a more kinematically appropriate knee, a more natural knee, a more personalized knee for their body. I think that the kinematic alignment philosophy, I'm a big believer in it. I really do. I think bringing it to the masses has been fraught with difficulty. Um, whether it's kinematic, inverse kinematic, how do you decide depth of cartilage wear? There are some true geniuses behind the kinematic alignment philosophy. You know, and I think that as like for the masses has been difficult. I think we would have seen a lot more kinematic alignment surgeons before robotics, and now we are seeing a huge shift in mentality in terms of how knees are balanced because of robotic systems, and that goes for think surgical or not think surgical. I think the reason to use think is beyond just the idea of I think there's reasons to use it. I think robotics is really going to be here to stay, because I think that the Debbie that was trained robotically, it's my hope, and maybe I'm kind of biased because of my training, that their patients at 10 years feel that their knees are more natural and arguably potentially lower failure rates. It's hard to know for sure, but theoretically, tibias and a little bit of varus are perpendicular to the ground more than a standard mechanical tibia. So I don't know where the future holds, and cementless designs I think are going to be a big part of this. But my hope is that maybe at 10 years, Debbie 2 has fewer, less patients that feel that their knee is unnatural and clicking and a little bit lax, and more patients that, have potentially, I hope, a forgotten knee at 10 years.
Great. Yeah, yeah. The two
I,
Yair Kissins.
I mean, I think it's such a good philosophical question. I mean, you can't forget that a knee replacement, for the last 30 years, 35 years, been a pretty good durable operation. I see my Kelly's follow-ups from 20 plus years ago, and they're doing great. And, they just come every 4 or 5 years. You can't forget that that's the case. And then you wonder, why are we doing all this? And why are we fighting about restricted versus non-restricted kinematic when all of that philosophy worked, and yet I don't do a single PS knee anymore, which is what I was trained on. So there must be some year 1.5 in the middle there that kind of needs to remember those principles and not forget them, because at the end of the day, the lights could go out. You still might have to use a knife and fork to get to the end. You have to know what you're doing, why you're doing certain things. We've now, I think, robotics has, in a timely way, come when we're still arguing about which is the best way of doing knees. And I think what's coming to fruition is that there are several different ways to skin that cat, and they may all be okay as long as you're doing it correctly. These tools are going to allow us to do that and even measure that. We're going to have actually objective data to say that we are balanced, that we are correct for a valgus knee. It should maybe be done this way for a bad varus knee with a flexion contracture this way. Um, I think what's important here, what I find when I was thinking about your question, is that we're actually still doing a very close to traditional non-robotic knee and yet using robotic technology. And I think that that is something that to make it more universal, more I think this will be a gold standard kind of tool to do knees. I mean, it's really that simple. Whereas bringing in, something completely different that completely changes the way we do things in the operating room, you need something that is more universal to really be accepted. And then it opens up that area to say this philosophy works with this kind of knee and this with that kind of knee. So the traditional guy you can't forget tradition, okay, and you can't forget those principles, but this is an enhancement on that. I think that residents today, as we teach them, at some point it's going to be majority robotic at some point in our big institutions. We can't forget to teach them those principles and for them to teach it to the next crew.
No, it's a great point. I mean, as far as it becoming the standard, I recall reading when I was a resident, which was a little while ago. There was an article in Clinical Orthopedics. It was an editorial by a gentleman from, I think, Adams, Massachusetts. I'll dig it up. It's called Keyhole Surgery. And what he was talking about, how this newfangled arthroscopy stuff is never going to click. It's never going to work. You need an incision to see everything. How can you possibly do anything through tiny little keyholes? And you know, and I actually reread that recently, and it was so beautifully written, but so incredibly wrong. And the reality is, um, maybe even faster than we think, robotics will be the gold standard. If you're not using it, it may just be you're out of standard at some point in time.
But isn't that funny? So I don't know how to do an open ACL reconstruction,
Right.
right? So never, I never will, right? So
What are you
yeah,
talking about? You were my resident. I taught you. Are you out of your mind?
taught me gamma nails.
So let's change to go in the operating room. Hello, Dr. Plancher. How are you?
I'm fine, Dr. Kirschenbaum. I'm sorry when I get irreverence out of the smart Dr. Kissin, I have to go on the attack.
Say no more. Uh, for those of you who don't know Dr. Plancher, you're living under a rock probably, but I will make a shameless plug for Ortho Summit
Thank you.
2024, which is this September 13th to 17th, 18th.
18th, sir.
Yep, and probably the best course in the country. I'm going to tell you that now and embarrass him. But
Thank
it was really, really an amazing course, and all this kind of stuff will be covered there. So thanks for joining us tonight, Kevin.
It's my honor, and think we'll be there and probably with Yair. So, and Eytan is traveling, I think, but we're very honored and thanks for that shameless plug. We thank you.
It's all right. It's a specialty of mine. In the operating room, is there ever a point you have to change your plan? I'm talking about with the TMINI specifically.
So
You have this plan, you're doing this plan. What are those moments? And describe a few of them. And maybe if one of you has a case study you want to show.
yeah, if I can share my screen, I think
Yeah,
I'll.
go ahead. You should be able to.
So this is a very simple one that kind of I wanted to pick one that is just universal. We've all been there kind of case. Oh, sorry, that was the end. I showed you the last page instead of the first page. So here is our guy, pretty bad varus, not a whole lot going on in the back of the knee, as far as osteophytes, but he's got a, good flexion contracture back there. So in the operating room, so preoperatively, I planned my usual femoral placement at kind of right at the depth of that intercondylar notch and taking enough that the distal part of the implant is 9 millimeters, making sure to take about 9 or 10. I knew that he had a flexion contracture, so I proximalized it about a millimeter on the preoperative plan and thought that, we'll assess it in the operating room. And then once you've done your registration, if you pass registration, then that means you can then do a pre-cut assessment of that knee, and it showed that there was a 13 or 14 degree flexion contracture, which was accurate to what my eyes were seeing. So then I moved it up even a little bit further, proximally, and ended up, with I don't think you can tell that it's not like I did a distal femoral replacement here. It doesn't look like it's overly proximal, but it was one cut. The point of this case to show is that it was one cut, with pre-op planning as a plan of taking a little bit more distally, intra-op figuring out that it's a little bit tight still. So before I cut, make it a little bit more proximal, one cut, 10 millimeter poly. And that was that. I didn't have, if I needed to recut, you can with this system, but I didn't need to. It allowed me the flexibility to get a preliminary plan, to intra-op assessment, to intra-op change, to 10 millimeter poly. And then the corollary to this case was that I had the opposite, which was a recurvatum case. So I put that femur where I would normally put it, at the bottom of the notch. Intra-op, there was about a 10-degree recurvatum or so. So I distalized the femur. If you think about it, when you do a non-robotic knee, you put the sword down, you make the cut, and then you figure out that you've taken too much, a lot of times. It's a little late. And that allowed me, before cutting, to do something that I probably wouldn't do normally, which is really put the distal femur, a lot more distal, the distal femoral cut. So that to me was nice to see that an ugly knee, and I just needed to do one cut, no recuts, and a 10 poly.
That's great. Eytan, your experience in the operating room changing flight plans?
Sure. I have a case. I can throw it up.
Yeah,
Nothing
please.
nothing major here, but we can just kind of talk through it. Give me a split second here. Do you see
Yeah, we
that?
got it. Yep.
Let me just flip it. I don't know how to flip it. Oh, here we go. Here you go. So this is a relatively straightforward case. So 76-year-old female, with bone on bone arthritis of the left knee. These are her radiographs. Some of the stuff that I think you really capture, with the CT scan, are these osteophytes, and it helps, like Yair said, is to really understand, where those osteophytes are. This particular patient, had a lot of difficulty in flexion of the knee, so as opposed to a flexion contracture. This particular patient, had what was likely a chronic ACL tear and a lot of difficulty in flexion of the knee. Um, Now, in this particular case, we were sizing her femur very carefully, with this system that I was planning to use. Very little flexibility in terms of the one up, one down rule on this system. And so, intraoperatively, really being able to assess implant sizes was important here. Right now, intraoperatively, when I make the decisions, I'm deciding if to take a little bit more femur or more tibia. But now with the TMINI Pro, it's like any other robotic system where you're balancing the knee, you're assessing your medial lateral gaps, both in flexion and extension, and you can make adjustments on your implants intraoperatively, in order to better balance the knee. In this particular case, really didn't require a ton of intraoperative balancing, but it did allow us to size the components. Um, and here you can see these are her post-operative films, and a few things here that the system really allowed us to do very nicely. I personally use a CR type construct. In her case, very tight inflection. We added the appropriate slope. I also posteriorized the tibial component, in order to kind of keep that posterior rollback that she was having, due to her chronic tear. And then also you can see how tight the sizing is here. This is a minus type implant, and you can see just how millimeter it's sized for her. And this is just very elegantly done with a image-based type robot. Personally,
So
I'll stop sharing that.
sure, absolutely. Um, a question. I just on a practical level, you're in the operating room. Is there a screen that like if you sat there and said, what would happen if I cut off before I make my distal cut? What would happen if I cut off 5 millimeters more? Who runs that screen for you? I mean, what are the
Do it.
practical?
You can do it, or in my case, you can. That's the flexibility of this system.
Okay.
Is that the footprint is that of a free OR lamp, basically, that you can roll in. It's less than a arthroscopy tower. It's less than the other systems. So I have it on the opposite side because I usually will have one assistant to my right, which will be if I'm doing a left knee. So I'll be in front of it. On my right, the med student. On the other side of the table is my PA and the resident. So we can have four people there, and there's still room for the screen on the opposite side. So that's the beauty of it, Ira, is that anyone can do it.
How do you
Any
control the screen? Is there like a
touch screen.
touch screen, a sterile touch screen
Yeah.
kind of thing?
Yeah.
So you don't need a think specialist in the room.
No, it always
Except
helps. It's
yourself.
always nice. It's always nice, but
Oh,
no,
but I meant need, like require.
correct.
Right.
Correct.
You learn how to use it. It's good. Have there been cases where even with the TMINI, there are certain cases where it's hard to adapt to the anatomy there, maybe very bone loss, how does it handle bone loss and using augments and such like that? Would that be
I,
you don't
I had a case where there was an old ACL screw, and we worked around it. It wasn't really an issue. I can't think of any. I can't think of it. Yeah,
The
it's bone to bone. So
Yeah, what's nice about the system, right? The end effector is pin placement, right? So at the end of the day, you're using cutting jigs, which are traditional, right? So all the bone loss and things like that you're dealing with on your own with your own saw blades. And so from that standpoint, it's very minimalistic and really not affected tremendously by osteophytes or complexity. A lot of that is tackled preoperatively based on the CT planning.
So we have a question from the audience, Roham Borajani. Roham, you want to unmute yourself or maybe on video and ask your question? No, no apologies. You interrupted. It's all good. Want to ask your question, please?
Hi, nice to meet you all. Sorry to interrupt. I have a question. To avoid replanning during the OR, as our two faculty mentioned, uh, do you think that standing CT images instead of the routine laying down ones might be helpful? Because I think there might be some conditions that standing may change knee alignment, and if we capture these conditions, it will help us to avoid replanning or re-registration during the OR.
I think it's a great question. Standing CTs are very cool, and I think they are useful for potential multiple reasons, but I don't think they necessarily will help with the question you're asking. Many of the preoperative planning that we have right now is basically based on anatomy, right? So we're sizing the components to the patient's bone, whether they're standing, sitting, jumping. We're just capturing the CT scan so we get the actual anatomy of the bone. The bone is segmented. I do think standing films are important, and I get long leg standing films on all my patients because it gives me a target for those patients. So I'm able to already get an idea of, okay, this patient's native tibia and is 3 degrees of varus, and their native femur is in 2 degrees of valgus, right? And so when I'm in the OR, I'm predicting that that's what I will need to do. And in preoperative planning, I'm putting the implants already in those positions because I'm assuming that's what's going to balance the knee. Now, intraoperatively, I assess the balance and will change those based on what I think the patient needs. And I have certain thresholds. But I don't think the standing CT scan is absolutely necessary. I think just standing films are fine. And the other challenge with standing CT scans is that many of them don't capture the hips right now, and we need the hips for the center of rotation of the hip with image-based systems. So maybe in the future, but something to consider. It's a great question.
Thank you
It,
so much. Thanks for clarification.
it's interesting. And also, the question you ask to avoid replanning. I'm not trying to avoid replanning. I kind of rely on both. The static plan preoperatively just gives me an idea of kind of where that ballpark is. And then intraoperatively, if I don't have to make any changes, I think that's a huge win. And I think that's ultimately our goal. But the fine tuning so that we've found the ballpark, but now we've really found the goal when we're already there, I think that is really what I'm going for. And just having experience with the T Solution One with the big robot where there was no intraop flexibility, I think surgeons really wanted some. And I think that was part of the need for adoption to something that does allow us to change. So I kind of like the plan of replanning being an option.
I can see that. Thank you so much.
No, that's great. I want to share my screen. I want to show something, I think. Hold on. So I need you to explain this to me. Think Surgical now had just recently, July 23rd, which is yesterday, got approval for 1.1 system. Okay, the 1.1 system. So it must be news because it says news. That's how I know. That's how I know it's news. Okay. What is this new? Do either of you know what this new advance is all about?
Yeah. So as Yair said, the magic happens intraoperatively, right? This is where the excitement occurs, right? We can balance the knee, we can assess the gaps, and we can kind of personalize the cuts of the knee for each patient. Um, the first version of TMINI, the intraoperative changes that could be done were limited. They were limited to basically taking more femur or taking more tibia or taking less femur or taking less tibia. We weren't able to change varus or valgus or rotation of the femur intraoperatively very well. It would be a it's a it would be a it's a currently it's a hassle. But the goal was to get it out on the market and have surgeons and staff and the community as a whole get an idea of what this device is like, and break the barriers in terms of a handheld device in the OR and some of the other stuff we've already discussed. Right now with the TMINI 1.1, TMINI Pro, this is the basically this is, in my opinion, this is the kind of the engine of the Ferrari under the hood. This is the magic, right? So right now, intraoperatively, we're going to be able to get all our gaps, change the implants, in any way you want. And you can have at it and really determine intraoperatively how you want to change the implant and personalize it for each patient. And so that's really, to me, this is a huge stepping stone and really puts TMINI on the same footing as any other robot, and I think it adds a lot of depth and breadth to the case.
Yair, any comments on that?
This is basically, I think, what the audience has been asking for. If the adoption of robots over these years has only been about 20% penetration, there's got to be something about it. So if we can create a device that can be universally put in somebody's hand and still be doing a pretty familiar surgery, but still be able to change in every which way, like Eytan said, in every varus valgus rotation. Ultimately, my feeling about what robots enhance for me is that femoral placement. I think any one of us can cut a tibia pretty well, pretty much where we want it, recut it into a little varus if we feel like we need to. But that femoral placement, when you realize that rotation of a native femur, of a native human femur, goes from about a few degrees of internal to 9 degrees of external rotation, but we cut everyone at 3, or parallel to the epicondyle axis, then we're doing it wrong a lot. And what this allows us to do is that last bit of fine tuning. Roham, this is that last bit of fine tuning that I love, because this allows me to not have to make any corrections with soft tissue releases which I think, you know, a lot of us think might lead to more pain and more of an unnatural feeling knee because we've had to really alter a lot, not just the bones, but the soft tissue. And soft tissue releases traditionally are basically done to fix the mistakes of the bone cuts, is how I kind of always looked at it. We don't put that osteotome down the medial tibia anymore like we used to, and like some of us were taught. If you can fine tune it, especially like Eytan said, rotation, that's really the key. And then you can balance your flexion, your extension, dare I say, even mid flexion, and be able to feel like you put the implants in the right place for that patient.
Really, when you've been around enough, you know that the only thing that ruins the surgery, of course, is long-term follow-up, or post-operative follow-up. I have found in seeing a lot of patients as second opinions that the hidden, I'll call it the hidden number one reason for dissatisfaction is subtle instability. That's what I feel is I see that a lot. I see people with achy knees and they're just they're not too unstable to be falling. And what are your feelings about, and maybe traditional ways of doing these, just people just didn't get the gap balancing perfectly and just followed the jigs. Um, does the TMINI force you to really gap balance right? I mean, is that a solution for these unstable knees I'm seeing in clinic?
It does give you an assessment, like a lot of systems do. It does give you that dynamic assessment as you put the knee through a range of motion with the trials in. I can't honestly say I'm confident to say that Eytan understands those curves a lot better than I do. But what I can understand is that when we start with a knee like I showed you before, and that whole curve is over to the varus side from extension to flexion, and then we do our implant placement, put our trials in, and that curve is now in the middle, close to the zero line. I think we've hit our goal. So there is actually an assessment, and I think that if you have a tool that can get you there and get you there reliably and reproducibly, then we might be able to then put those implants in the right place,
Yeah.
full range of motion, not just for 0 and 90.
I think I think the mid flexion discussion is obviously important. But I think there's a lot about knee replacements that unfortunately is not natural. There's no ACL. Um, PS knees we know have some challenges, and I think are forgiving from a surgical standpoint. And CR knees are a double-edged sword, and maybe a very balanced knee kinematically, but done in it can have other issues. Such as stiffness. And I think that if you ask, Steve Howell, this great talks in kinematic alignment, and he
Yeah.
gives. I think he had one saying where X-rays look great, but patient walks a few blocks, has pain, and you say, oh well, you should be happy that you have a knee. And I think in reality, I think it's like you said. I think there are there's kinematic challenges with knee replacements placed in traditional mechanical alignment in some patients. So in some patients who have a very oblique joint line, a kinematically done a knee that's traditionally in standard mechanical neutral alignment just may not be perfect for them and how they feel. And it may be inflection instability, maybe some other sensation. It's something we're actively studying. And I think that, like you said, long-term follow-up is going to be key. I think with technology and robotic systems such as Think Surgical, and now with this new balancing software, we're able to get much better kinematically aligned knees. We're placing the implants, we're cutting the same amount of bone and cartilage, placing the metal where it needs to be placed. We're doing a lot more cruciate retaining knees and obtaining full range of motion. And I think that doing that, and you can see, Yair and myself, I think we were trained in tons of PS knees, and now I'm doing CR with my robotic systems all the time, and the knee is well balanced with great motion. And do those patients feel perfect? I don't know. Let's ask them in 10 years. But I think that the knee feels a little bit more natural than a necessarily mechanically aligned knee in certain patients. In those patients, a lot of varus or a lot of valgus.
It's interesting when I trained with in knees with Bob Booth and Dick Rothman and Bill Hozak. And Bob Booth used to say that balancing a PS knee was like tuning a Chevrolet, and working on a CR knee was like tuning a Ferrari. And the TMINI probably helps a lot with that kind of tuning, especially with the PCL not being as perfect.
Yeah,
Uh,
I think it's a great analogy. I've never heard that. I may steal that from you.
yeah, you steal that from me, but I'll defer back to Bob Booth, who said that.
We'll have to get him on the conversation. But I think the CRNE is challenging. It is doing it right. I think there are surgeons who do it with traditional tools, and I think have been trained well in it. And I think that um, the technology allows us to do a cruciate retaining type knee well. And I think that PS knees will you'll see in our registry will come down in usage as we see technology rise, and that's my prediction. And satisfaction, we will see. That may take longer to prove.
And don't you think that the congruent part, whether it's media congruent, ultra congruent, we'll see if it's a lateral side, medial side, whatever you believe in, the dual congruent. There is something to that. I've been using it now for 5 years, and I think I see a difference. I think time will tell. But if you're doing a PS knee mechanically, right, and and putting in an ultra congruent or medial congruent poly, I'm not quite sure that that's necessarily the right thing. But if you are putting it where it belongs on that patient's anatomy, then that congruent poly may actually be the answer to some of that subtle instability, because we all see it, we all have it, and it's tough to see it, and know what to do about it. Because what do you do about it? You have to go and put in a constraint. If you're going to do something, it's pretty major, massive surgery.
Yeah. Is there, let's talk about learning curve for a second. Um, I have a sense that assuming you are a accomplished knee surgeon, um, it seems to me that this would be a relatively short learning curve on this. It just seems to me. I may be
Well,
wrong.
I had the medical student put it in yesterday, put the pins in. So I think they didn't do the whole planning and everything, but from an end effector standpoint, you don't have to be an accomplished or big knee surgeon to use the tool as an end effector. I think obviously experience is important for
Yeah.
balancing and assessment and all that. But as an end effector in the OR, it's kind of marrying the traditional with the new, and I think that's part of the magic.
I think the
Yeah.
learning curve is more what is standard for all of these robotic systems is putting those pins in without getting a fracture, making sure you're putting it in the middle of the bone and doing registration. I think that people rush through registration. You really have to pierce the cartilage. It's CT based, so you have to be down to bone. And when you fail registration, you might have been going a little too fast. I take an extra 30 milliseconds or so per point just to make sure that I just do it once. I'm not going for any speed records, but better to just do it once. Once you get that, the actual parts of the case that are TMINI, proprietary TMINI parts, are pretty straightforward.
If you're taking that 0.3 seconds, we just did a whole series with Charlie DeCook and his 12 by 12. You're going to be doing 11 by 12. So, I mean, I don't know. Maybe you just can't get a job in Atlanta. Yeah, leave the New York area from Atlanta. So we're at the 8:55. I want to show something on my screen. This is a cadaveric surgical demonstration featuring the T-Mini Pro, August 20th, 2024. I think Trevor Cotter, you're on here. If you could just say where this is going to be, um, if you're available, Trevor.
Yep. So there's a link in the chat for anyone that is interested in registering for this. As Dr. Kissin and Dr. Debi mentioned before, this is the full intraoperative adjustments and a demonstration of using that with the T-Mini system. This is what was announced yesterday with the 510K clearance. Thank you.
Excellent. Yeah, I see the registration link there, and that's good. So I'd like both of you to sort of sum up a little bit and say some final words of wisdom for everybody here. It's been a very good turnout and a very important topic, real cutting edge stuff. Eytan, you want to start us off on summing up your general feelings about this?
Sure. Well, first of all, thank you for having me. It's always a pleasure, Ira. A lot
Thank
of
you.
fun and great questions. I think, you know, I think robotics is here to stay. I think it's worthwhile committing and learning this whatever system you think is best. I think really consider Think Surgical as an option for you if you'd like to have that versatility either with yourself or with your group practice in terms of different implant systems you'd like to use. And I think if you're doing surgeries at surgery centers or plan to or have small ORs or want a system that's really easy to use, an open platform with excellent outcomes, I think it's a great option to have in your tool belt.
Yair, we want to bring us home for tonight?
Yeah, very hard to follow Eytan. This guy's it's been a pleasure working with these people that I've had to work with, and so much thanks for having me on this tonight. But what I will say is that for those of you who haven't tried robots or are not particularly, thrilled with your experience, don't worry. We've done all the work to make this as easy as possible. It's really a tool that is just it's so easy and it gets you to where you want to go. It's really that simplified. So for those who are hesitant about doing robots, this may be, I think, a gateway robot for a lot of people where it doesn't feel very foreign from doing a knee replacement the way you've been doing it the whole time. Just a couple of added steps and time wise, and we've been timing it, the time is not that prohibitive. In fact, we even did one faster than one. I did one TMINI that was faster than a traditional knee. It means it can be done. That's kind of a holy grail, I think. And after using different systems, if you can find a system that gives you the implant you want, you can use the philosophy you want. Okay. Your OR staff, we didn't really mention them very much. They don't mind this so much. Most OR staff does not like using robots because it's a lot of work for them and a lot of unnecessary work because there's all kinds of extra stuff to use. There's not a lot of stuff here. So this is just one of those tools that I think will just be ubiquitous soon enough.
That is great. And I want to say a few final comments. Great to have both of you on board. Um, you're really superb at this and what you do and the advances that you're doing in the robotics, I think to be seriously commended. Um, and I want to thank you guys for joining us and thanking everyone who joined us tonight. As always, this is recorded and will be on the JOEI website as well as on YouTube. And as well as on a Spotify podcast. So when you drive to work and you have nothing to do, uh, and you've listened to every Nora Jones song already, then you would probably listen to this podcast, and you should. And you should spread the word. I want to thank everyone who's come and say good night to everybody.